Welcome to section 2, acute decompensated heart failure, ADHF, and yes, I said the heart can't even because that's genuinely what's happening. The pump is failing, fluid is backing up, patients can't breathe lying flat, they're showing up to the ED at 2 a.m. having slept in a recliner for the past week because lying down feels like drowning. ADHF is one of the most common reasons for hospitalizations in the United States. It has a 30-day readmission rate that will make you wince. And a lot of those readmissions are preventable with better medication management, better discharge planning, and pharmacists who understand the pathophysiology. So, today we're going to talk about how to classify these patients, what drugs we use acutely, why you should almost never stop someone's chronic heart failure meds in the hospital, and a few newer agents that are changing practice. Before you give any drug, you need to classify your patient, and the Forrester framework is how we do that. Two axes. Is the heart perfusing adequately? Warm versus cold. And is the patient volume overloaded? Wet versus dry. Four quadrants, four completely different treatment approaches. Oops, let's go back. Subset warm 1, which is the warm and dry. So this patient has normal hemodynamics, no congestion. These are your compensated heart failure patients. They don't need acute intervention. You optimize their guideline directed medical therapy and send them home. Good for them. Now, subset 2, the warm and wet, they're perfusing fine, but they're fluid overloaded. Pulmonary capillary wedge pressure above 18. This is your most common ADHF presentation. First move, IV diuretics. If blood pressure allows over 90 systolic, you can add IV vasodilators to speed up the decongestion process. Subset 3, you're cold and dry. Hypoperfusion, hypoperfusing, but not congested. Maybe their PCWP is below 15. First, give fluids to optimize filling pressures. If the wedge pressure is adequate and BP is below 90, inotrope. If BP is above 90, consider a vasodilator to reduce the afterload. Subset 4, you have your cold and wet patients. The skull emoji on that slide is accurate. This is your sickest patient. Fluid overloaded, and not perfusing. You're giving diuretics. If BP is above 90, you layer in a vasodilator. If BP is below 90, you want to give an inotrope. Some of these patients need a vasopressor too. So before you do anything, classify the patient, warm or cold, wet or dry. That 2-second assessment changes everything about your drug selection. All right, drain the swamp. The title alone is a vibe. Diuretics, the foundation of ADHF management for wet patients. If they are wet, we need to make them not wet. Simple concept, nuanced execution. Loop diuretics are your first line. Furosemide is the workhorse, but bumetanide and torsemide are in the family too. So the key clinical pearl here is for a patient already on oral diuretics as an outpatient, you cannot just continue the same dose intravenously. The conversion math matters. So oral furosemide, 80 milligrams, equals 40 milligrams of furosemide IV. And then you multiply that by 1 to 2.5 times to get your starting inpatient dose, IV dose. So a patient on oral furosemide 80 twice daily might need 80 to 200 milligrams IV twice daily. That feels like a lot, but gut edema impairs oral absorption. IV gets around all of that. If loops aren't working well enough, you can add a thiazide to hit a different part of the nephron. Sequential nephron blockade. Metolazone, 2.5 to 5 milligrams orally, given 30 minutes before the loop diuretic. Chlorothiazide intravenously if they cannot take anything by mouth or if there is GI edema. Be ready for some electrolyte losses when you combine these two. Acetazolamide, the new kid on the block in ADHF management, 500 milligrams IV once daily as an adjunct. It hits the proximal tubule, a completely different mechanism, and recent data shows it improves decongestion and diuretic response. It's a reasonable add-on, especially in patients with resistance. Diuretics resistance is real. When it happens, step up the dose before you increase frequency. There's a ceiling effect around 160 to 200 milligrams of IV furosemide. If that's not working, switch to a continuous infusion, 5 to 20 milligrams per hour. Add a second diuretic, consider an SGLT2 inhibitor. There's data showing empagliflozin started within 12 hours of admission increases urine output by 25% over standard care. And ultrafiltration is on the table for truly refractory cases. This is the slide that trips up a lot of clinicians. When do you use a vasodilator versus an ionotrope? And the answer comes directly from that Forrester classification we just did. If the systolic blood pressure is above 90 and the patient is fluid overloaded, you reach for a vasodilator first. Better safety profile, less arrhythmic risk, and in many warm and wet patients, getting the preload down with a venodilator gives them faster symptom relief than waiting for a diuresis to kick in. IV nitroglycerin starts at 5 micrograms per minute and you titrate up to 200. It's predominantly venous at low doses, which drops the preload, but at higher doses, it also hits arterial resistance. So this is a great choice for patient who has ischemia on top of their heart failure. It's treating both simultaneously. But watch for tachyphylaxis though. This can develop within 24 hours. Then you have your nitroprusside, balance arterial and venous. Really useful when you need to aggressively reduce afterload. Cold and wet patients with high SVR who still have decent blood pressure, but this drug demands an arterial line and close monitoring. Cyanide toxicity is real with prolonged use or high doses, especially in those with renal failure. And avoid it if there is active ischemia. The coronary steal syndrome is a risk. Now, ionotropes. These are for cold patients, low cardiac output, low blood pressure, and organ hypoperfusion. Dobutamine is a beta 1 agonist. It increases contractility, heart rate, and has mild peripheral vasodilation, but it's counteracted by beta blockers. If your patient is on carvedilol or metoprolol, dobutamine may not work very well. Then we have milrinone, a PDE inhibitor, increases C-amp, increases contractility, and also vasodilates. It works independently of beta receptors, which is why it's often preferred when a patient is on a beta blocker. It also reduces pulmonary artery pressures, so if there's significant pulmonary hypertension, milrinone may have a pharmacologic advantage. Key warning though, avoid the bolus because it can cause hypotension. And milrinone is 90% renally eliminated. So dose adjust or use dobutamine if there's a significant renal impairment presenting in this patient. A key thing to note here is that both milrinone and dobutamine are pro-arrhythmic. Both have been associated with increased mortality with long-term use. So use them to stabilize. Do not use them indefinitely. This slide might be the most practical, important slide in this entire section, and it's not about what not to do. Do not reflexively stop your patient guideline directed medical therapy when they're admitted for heart failure decompensation. I cannot tell you how many times I've seen someone admitted for heart failure, and by day 2, every single one of their chronic heart failure meds have been held. Beta blocker held, ACE inhibitor held, spironolactone held, and the data is really clear. Stopping beta blockers in optimized HF was associated with higher mortality compared to those who were continued. These are not the drugs that decompensated the patient. Stopping them is what made the outcome worse. So beta blockers, keep them unless the ADHF was caused by recent initiation or dose increase of the beta blocker itself, or if there's cardiogenic shock, symptomatic hypotension, or bradycardia. Small decrease in blood pressure or mild bump in creatinine, keep it going. Restart as soon as possible if you do decide to hold. Your ACE inhibitors and ARBs, keep it going. A creatinine rise of less than 20% from baseline from ACE inhibitor use is acceptable and does not predict worse outcomes. The time to stop is if they are worsening in renal function after recent initiation, symptomatic hypotension, or potassium above 5.5. Mineralocorticoid antagonists. Keep this unless potassium is climbing, and your SGLT2 inhibitors. Keep unless there's acute kidney injury with GFR dropping below the threshold of a specific agent. Digoxin. Continue at a dose that maintains a level of 0.5 to 0.8 nanograms per milliliter. Do not stop it unless there's a compelling reason, whether it be bradycardia, life-threatening arrhythmia, toxicity signs, or digoxin withdrawal, or toxicity signs. The digoxin withdrawal actually worsens heart failure symptoms. Okay, now 5 things to lock in from section 2. 1. Classify before you medicate. Warm or cold, wet or dry. Every drug decision in ADHF flows from that 2-second assessment. 2. Diuretics first for wet patients. IV dose at 1 to 2.5 times the oral equivalent. When they start responding, escalate. Higher dose, continuous infusion, add a thiazide or acetazolamide. 3. Vasodilators before inotropes when the blood pressure allows. Inotropes are for cold patients and carries real risks. Don't skip vasodilators because inotropes feel more dramatic. 4. Do not stop the chronic heart failure meds. Small creatinine bumps and blood pressure dips during diuresis are expected. Stopping ACE inhibitors, beta blockers, and MRAs in the hospital makes outcomes worse. We have the data. 5. Bonus points. Tolvaptan for clinically significant hyponatremia associated with heart failure. BNP and NT-proBNP for diagnosis and prognostication. Remember, NT-proBNP is preferred in patients on sacubitril in combination with valsartan because sacubitril affects BNP clearance. And SGLT2 inhibitors and empagliflozin data shows meaningful improvement in decongestive outcomes. These are coming. Section, oh, wow, I can't say that word, but section 3 is arrhythmias. VT, your VFs, your ACLS algorithms, AADs, and when to get a defibrillator implanted in someone's chest. Don't go anywhere. That's coming up next.